Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at appendicitis. So if you haven't yet subscribed, please hit the subscribe button, hit the bell notification icon to be receiving notifications every time I post such videos. Drop a like, drop a comment to show some support, share the link to your friend to tell a friend that we are looking at medical topics on this channel. So what are you waiting for? Let's jump into the topic. Grab your piece of paper, grab your pen, and let's go. So before we actually go into details of talking about the appendicitis, you should have functional knowledge of what the appendix is. So remember that the appendix can also be referred to as the vermiform appendix. Vermiform meaning that it looks like a worm. And this is obviously a structure that's going to be budding off from the cecum at around the 6th week of embryological development. So the appendix develops from the 6th week of embryological life. So this appendix is obviously going to be a narrow tube. It has variable length. So it can be as short as 2 centimeters. It can be as long as 20 centimeters. And the base is going to be attached at the posteromedial surface of the cecum, close to the junction between the ileum and the cecum. So the location of the appendix is going to be at the terminal end of the cecum, where the 3 tinea join. So if you're in theater, this is actually a very important feature to know, because you can actually follow the tinea to where they converge, and that is obviously where you're going to be finding the appendix in that proximity, about 2 centimeters below the ileocecal orifice. So the length, like I said, may be variable, about 2 to 20 centimeters. The diameter of the appendix is about 3 to 8 millimeters. The size of the lumen is about 1 to 3 millimeters, so almost the size of a matchstick. The capacity is less than 1 millimeter. And when it comes to the blood supply to the appendix, the mesoappendix is actually an extension of the mesentery, and it's going to be containing an artery, which is referred to as the appendicular artery of Schischelen. So this appendicular artery is actually a branch of the ileocolic, which is a branch of the superior mesenteric artery. And remember that the appendicular artery is actually an end artery. What do I mean by an end artery is it doesn't have any collaterals. So it means that if this artery is blocked, meaning the main blood supply to the appendix is blocked, this can easily lead to gangrene. It can easily lead to perforation. So the base of the appendix actually remains in a relatively fixed position with respect to the cecum, but you can have the tip of the appendix that can end up in various positions. There are about 6 positions that you really need to know. The most common is the retrocecal appendix, which is the most common, the one that is depicted as A here behind the cecum. You have the periileo appendix, which is what's depicted as B. Pre-ileo rather, not periileo. Pre-ileo, before the ileum. Then you have the post-ileo after the ileum, which is abbreviated C here. You have the pelvic, which is D. You have the subcecal, which is E. And you have the paracecal. So those are the 6 positions. This should be peri, not pre. It should be pre rather, not peri. So this should be pre-ileo. I think let's correct that so that most of you don't misquote me on this. So this should be pre-ileo. Pre-ileo. Let's save that. Okay, fine. That's great. So this should be pre-ileo. So you have the retrocecal, pre-ileo, post-ileo, pelvic, subcecal, as well as paracecal. And the layers of the appendix are going to be similar to the layers that you have in the colon. So you're going to have a mucosa, you're going to have a submucosa, you're going to have an intersecular layer, you're going to have an outer longitudinal layer. These 2 layers are predominantly known as the muscularis layer. Then you also have a serosa. Now in the submucosal layer, you have this collection of lymphoid tissue. So you have these lymph follicles, and these lymph follicles can sometimes become enlarged, especially in response to infections that may be either viral infections or bacterial infections. And once they begin to swell in the submucosa, they can actually block the lumen of the appendix, and this can actually lead to appendicitis. We shall discuss this later on. And when it comes to the function of the appendix, it's thought of as a vestigial organ. So it is actually considered by some to have some immunological function, and some actually believe that it secretes IgA. Other people believe that it acts as a store for the normal flora of the gut, to replenish the normal flora of the gut. However, it's not really an essential organ, and it can actually be removed without causing any severe immunocompromise in an individual. So when you're talking about appendicitis, I'm going to be focusing mainly on acute appendicitis. This is pretty much an inflammation of the appendix, and it is actually one of the most common surgical acute diseases that you meet on the surgical department, especially in the emergency setup. And it's going to be a very common variant in young white males, and this is because you get a peak that's happening when they have lymphoid tissue growth. You also get a second peak that is very common in the elderly. We shall see that in the elderly, it's more due to an obstructive cause, most commonly referred to as a fecal leak. A fiber-rich diet actually has been seen to prevent appendicitis, while the low-fiber diet has increased the chances of appendicitis. And sometimes appendicitis may be associated with certain seasons. You refer to that as epidemic appendicitis. So you may get some seasonal variations in May and August. This is only because due to the weather, people may contract viral infections. This may lead to inflammation of the lymphoid tissue in the appendix and blockage of the appendix, and ergo appendicitis. When it comes to the etiology of appendicitis, we still do not really know what may be causing the appendicitis, but diet has been implicated. So patients that have reduced a fiber diet, that's why it's very common in the West and very rare in Africa, but we do still get some cases of appendicitis. So the causes can be divided largely into two main variants. You can divide it into obstructive causes. You may also define it into non-obstructive causes. So these causes are largely obstructive, which are often due to obstruction of the lumen. So it could be a fecal leak, which is simply a small firm ball of stool, most commonly seen in adults, and it is associated with gangrene. It's also associated with perforation. You may have strictures, you may have tumors, you may have gallstones, you may have foreign bodies, you may even have round thread worms or even pinworms. You may have adhesions or even kinking, which is common with carcinomas of the cecum that are near the base. And you could also have ileocecal Crohn's disease. Some viral infections and bacterial infections have been implicated that may result in mucosal edema and inflammation that's leading to lymphoid hyperplasia and obstruction of the lumen. 80% of the causes are due to Escherichia coli. 30% are due to enterococci. Other causes include streptococci and anaerobic streptococci, Clostridium welchi, as well as bacteroids. You can also have pseudoappendicitis, which is often appendicitis that's due to acute ileitis following a Yersinia infection, and it is commonly seen in Crohn's disease. When it comes to the pathogenesis of appendicitis, we're going to be discussing it under two main headings. You have an obstructive cause, which is very common, and you have non-obstructive causes. Obstructive causes are very common in the elderly. Non-obstructive causes are very common in the young individuals. Obstructive causes are mainly due to a physical obstruction. Non-obstructive causes are mainly due to infections. So pretty much your viral infections, your bacterial infections, that's why they're common, because these are going to be leading to lymphoid hyperplasia. Then obstructive causes are common in the elderly, with fecal leaks being very, very common. So coming to the pathogenesis of the condition, so remember that you have a lumen in the appendix, and remember that the appendix is supplied by an end artery. So the initial thing that's going to be happening is going to be luminal obstruction. Now, this luminal obstruction may either be due to lymphoid obstruction in young individuals where they have hyperplasia, especially after a viral infection. So you get this condition where a child may sometimes even have an upper respiratory tract symptoms. Sometimes they may have a diarrhea, and then all of a sudden they present you with features or symptoms of appendicitis. So this is very common in young individuals. Then you may also have fecal leak, which is this small, hard, firm stool that is present in the appendix, and it's commonly seen in older individuals. And this blockage of the appendix is obviously going to be leading to an increase in mucus production. It's going to be leading to inflammation. Now remember that despite the mucosa of the appendix being blocked, the appendicular mucosa is going to continue secreting normally despite the obstruction. So you have this inflammatory fluid that's going to be increasing in the lumen. So now picture this. You have an obstruction, let's say, in the lumen. In addition to this, you keep secreting mucus into the lumen. So what's going to happen? You're going to increase the pressures that are present in the lumen. So the appendix is going to begin to distend. So it's going to dilate and increase in size. There's going to be an increase in the intraluminal pressure. And remember that whenever there is increase in the pressure within a cavity, the fluid or the pressures in that cavity are going to be exerted on the walls of this cavity. And remember that the blood vessels are traveling through the walls of the cavity. So there's going to be obstruction in the walls of the cavity. Now, the low pressure system vessels, such as the venules and the lymphatic drainage, are going to be affected first. If this obstruction isn't relieved, then this may lead to arterial supply being affected. So you have first blockage of the venous and lymphatic drainage. And remember, as you block this, there's going to be congestion of blood vessels within this appendix. So the resident bacteria are also going to begin to multiply even further and further increasing the intraluminal pressure. Now, you're going to have a point where the pressure within the lumen is going to exceed the pressure in the capillaries. It's going to exceed the pressure in the venules, but the arterial pressure will still be much higher than the luminal pressure. So it means that the arteries and the arterioles will still keep pumping blood to the appendix. So this is going to lead to vascular congestion. This is going to lead to engorgement. Now, if this obstruction isn't relieved, eventually there is going to be blockage. The pressure inside the lumen is going to supersede the pressure in the arterial blood flow. So this means that there's going to be some impaired blood flow. This may lead to mucosal ischemia. It may lead to ulceration. And when the mucosa is ulcerated, this makes it easy for bacteria to actually translocate or invade into the walls and actually spread into the bloodstream. So the bacteria can spread from the submucosa into the muscularis proper, and this can actually result in an acute obstructive type of appendicitis. The inflammation and ischemia can sometimes even progress and affect the serosal surface of the appendix. And if the appendicular artery is thrombosed, you have a blood clot that's there and it's completely blocked. It may lead to ischemia. And this ischemia can lead to gangrene. The gangrene can lead to perforation either at the tip or the base. And once the appendix is perforated, it means all the gut contents are going to be spilling into the peritoneum, and they can irritate the peritoneum, leading to a peritonitis. And then after the perforation has happened, sometimes you may have localization by the greater omentum. Remember that the omentum is the police of the abdomen. So whenever there's a leak somewhere, the omentum will come and cover up that leak and confine that leak. So it's going to be some localization by the greater omentum as well as the dilated ileum. And if there is suppuration, meaning if there is pus that is present within this localization that you're formed, you're going to have what is referred to as an appendicular abscess. If there is no pus, then you refer to this as an appendicular mass. Sometimes in acute appendicitis, where you have blockage at the opening of the lumen, you may have mucus that's collecting inside the lumen of the appendix, and the appendix can be enlarged. You refer to that as a mucocele of the appendix. Now, in the non-obstructive causes, you have acute inflammation of mucous membrane with secondary infection. There is no obstruction in this case, so you refer to this as acute non-obstructive appendicitis. In some cases, it may resolve. It may lead to fibrosis. It may lead to recurrent appendicitis. It may progress to obstructive appendicitis, because remember that with the hyperplasia of the lymphoid tissue in the submucosa, you can actually compress and block the lumen. Then it may lead to gangrene, but this is obviously rare. You may also lead to perforation and suppuration, which is pus formation. Now, the types of appendicitis are as follows. I'm talking about acute appendicitis and subacute appendicitis. I will not go into details about chronic appendicitis. So you have acute obstructive appendicitis. So here you're going to be having pus that's going to be collecting in a blocked lumen of the appendix. It may appear blackish, gangrenous, edematous, and it rapidly progresses and leads to perforation, either at the tip or the base of the appendix. So this can, once this perforates, it may lead to peritonitis. Like I already told you, it may lead to formation of an abscess, an appendicular abscess or a pelvic abscess, and most often it may lead to thrombosis, or there is thrombosis of the appendicular artery that may precede the perforation. Then you have a non-obstructive acute type of appendicitis or catarrhal type of appendicitis. So here you're going to be having inflammation of the mucous membrane occurring with redness. There may be edema, there may be hemorrhage, which may result in resolution, ulceration, fibrosis, suppuration, recurrent appendicitis, gangrene, and peritonitis. You may also have recurrent appendicitis where an individual gets repeated attacks of non-obstructive appendicitis, and this often leads to fibrosis, adhesions that may cause may cause these recurrent episodes of appendicitis. You may sometimes get subacute appendicitis, which is a much milder form of appendicitis. They may also get stump appendicitis, where an appendicectomy has been performed, especially with a laparoscopic appendicectomy, and they leave a large stump or a long stump of the appendix. It may sometimes even become inflamed. The clinical features, remember that appendicitis is very rare before the age of 2 years. And it's very common in other age groups and in children and individuals between the age of 5 and 35. You may have a Murphy's triad, which is going to be right lower quadrant pain. You may have vomiting or nausea and a fever or a high temperature. So do not confuse Murphy's triad with Murphy's sign, because they are different things. Murphy's sign is what you see in acute cholecystitis. For example, when you are palpating underneath the right subcostal region and you ask the person to take a deep breath while they're seated in bed, take a deep breath and you palpate underneath the right costal margin in the area of the gallbladder. Once the gallbladder comes into contact with the palmar aspect of your hand, then this is going to induce some pain, and they'll stop inhaling deeply because the gallbladder is inflamed. So that's Murphy's sign. Murphy's triad is what you see in appendicitis. Murphy's sign is seen in acute cholecystitis. So please do not confuse the two, especially on MCQ questions, especially on exams. So some symptoms include pain. This is the earliest symptom that we see in appendicitis. So it starts off as visceral pain that is often around the umbilicus. This is because there's going to be obstruction and distension of the appendix that stimulates visceral afferent stretch fibers. And of course, the distribution is T10. So the dermatome is at T10. You may get this characteristic pain that is dull or even colicky. Presumably, if it's colicky, that means there is obstruction of the appendiceal lumen. Then after a few hours, the somatic pain actually is going to occur in the right iliac fossa. This is going to be due to irritation of the parietal peritoneum, and the pain is often going to be severe and diffuse if it's spread to the peritoneal cavity, if there is a peritonitis, and not all the patients are going to have this characteristic type of pain. And the characteristic pain that usually is there with appendicitis, so it will start off around the umbilicus, then it will migrate to the right iliac fossa. So it will move to the right iliac fossa. It doesn't radiate, it will migrate to the right iliac fossa. So not all the patients may experience the shift of the pain, and they may just present to you with discomfort in the right lower quadrant. And in retroperitoneal or retrocecal appendicitis, the pain may actually be much higher in the right abdomen. Even in appendicitis that's located in the pelvis, they may have this vague pelvic discomfort, which often may be confused with pelvic inflammatory disease in case of women of reproductive age. Then patients often are going to report that they have this pain when they are making movements or when they are coughing. So a very good way to actually pick out appendicitis is just simply ask the patient to cough. If they cough and they're in pain, it could mean that appendicitis would be possibly one of the diagnoses. Peritonitis also can present in a similar way, where they have this pain, especially when they move. Then they may have vomiting and nausea, which are due to reflex pylorospasms. You may have anorexia, which is loss of appetite. You may have constipation, which is a common feature. You may also have diarrhea in 20% of the cases. This is common in the post-ilio and the pelvic appendix. You may have fever, which is low grade. You may have tachycardia. You may have urinary frequency. This is very common in a bladder that's being irritated by an inflamed appendix. So you really have to take note that if you're dealing with a child make sure that you ask about this child having sore throat or flu-like symptoms that may often accompany mesenteric adenitis. Then in female patients, you should ask about a history of dysuria, frequency, any cloudy or strong smelling urine, because UTIs can also cause low abdominal pains. And you should also ask about your menstrual history in the female, because a missed period can indicate that there may be some ectopic pregnancy, and an ectopic pregnancy on the right side may present similar to an appendicitis. So you do not want to miss an ectopic pregnancy and think it's an appendicitis and open up the abdomen and realize that this person has an ectopic pregnancy. Then sometimes this patient may have a mid-cycle pain, which is referred to as Mittelschmerz type of pain. So this is just the pain that's due to ovulation, which is happening around day 14. So you may also have some vaginal discharge that may indicate a pelvic inflammatory disease in women. So do not forget to actually ask for that and rule out for that, because pelvic inflammatory disease can sometimes be often confused with appendicitis. When it comes to the signs of appendicitis that you elicit on physical examination, you may have tachycardia, you may have mild pyrexia, or sometimes a high temperature, which is greater than 39 degrees Celsius. This is obviously going to indicate an abscess that is forming, or maybe some other diagnosis, such as a viral illness. The tongue is often furred. You may also have an appendicular mass or an appendicular abscess, which can be palpated in the right iliac fossa. You're going to be having abdominal tenderness. Like I told you, a very neat trick is to ask the patient to cough and watch out for their facial expression. So if coughing produces obvious pain, then the patient is going to be asked, where is the site of the maximum pain? And often they point either to the right iliac fossa, or they point to a point that is referred to as the McBurney's point. I will talk about the McBurney's point very shortly. Then there are some important signs that I want you to know of as a student. I will mention the most important ones that you should know for your exams, and then others that are going to be able to differentiate an A+ from an A student, a B+ from a B student. So this is, the first part is for like those that just want to barely just pass the exams. So you have a BLUMBERG sign, you have a pointing sign, you have signs that are indicative of peritoneal irritation, such as a ROVSING sign, PSOAS sign, and OBTURATOR sign. So these first 5 signs, BLUMBERG sign, pointing sign, ROVSING sign, PSOAS sign, and OBTURATOR sign, everyone should know them. Whether you want to clear exams, whether you want to distinguish yourself with an A+ or a B+, you should know all these exams. Now, if you want to go a step further, you may know about the Baldwin sign or even the Bastide sign. And you may also go on and talk about hyperesthesia that's maybe present in the Sheeran's triangle. Remember that Sheeran's triangle is formed by the anterior superior iliac spine, the umbilicus, and the pubic symphysis. So you may get some hyperesthesia in that area. And a rectal examination must always be done in patients with suspected appendicitis. It may elicit tenderness on the right. And in an elderly individual that's presenting with appendicitis, there may not be typical signs of appendicitis, so there may be a delay in the diagnosis in appendicitis because the pain is often less and it may present as a small bowel obstruction. Sometimes there may be a delay in the rise in the white blood cell count. And there is obviously a higher risk of perforation and mortality in older individuals than younger individuals, because the diagnosis usually takes time for you to reach. Then perforation at the time of surgery is more often seen in very young individuals. Those are below the age of 5, and in old individuals that are above the age of 60, because of the same issue of a delayed diagnosis. So here is how you elicit these signs. I will mention the most important signs that you really need to know for the sake of your exams and for the sake of your patients. So the first sign is known as a BLUMBERG sign, or you can call it the release sign. So this is just simply rebound tenderness. So you're going to, pain is going to be felt upon removal of the pressure rather than application of the pressure to the abdomen. This is often seen in the right iliac fossa in patients with acute appendicitis. So you're going to be applying pressure gently in the right iliac fossa, and then once you suddenly remove that pressure, then this person is going to be in pain. So you refer to that as a positive BLUMBERG sign. Then another way you could actually do this, if you want to be much more kinder to your patients, you may actually just percuss the area, and this may actually elicit the same response, but it's much less painful for the patient. Then this is also seen in peritonitis, though it would be a generalized type of tenderness. Then you have a pointing sign. So when you ask the patient to point with a finger at the point of maximum tenderness, they are often going to point at the McBurney's point. So if you draw a line from the anterior superior iliac spine to the umbilicus, 1/3 away from the anterior superior iliac spine and 2/3 away from the umbilicus, you refer to this point as McBurney's point. So this McBurney's point is obviously where you're going to be having the maximum area of tenderness in this area on the right side. And then you could actually make one of the incisions that is known as a gridiron or a MacArthur's incision about perpendicular to the McBurney's point. This is one of the approaches that you can actually use when performing an appendicectomy. The next sign is a ROVSING sign. So when you press into the left iliac fossa, there's going to be pain that's felt in the right iliac fossa. This is because of the shifting of the loops of Bow that are going to be irritating the peritoneum. The next sign is known as the PSOAS sign. So this is seen often in a retrocecal appendix. So hyperextension of the hip is going to be causing pain in the right iliac fossa. So what you're going to simply do is ask the patient to lay on their left side and at the edge of the bed. Then you're going to tell the patient to relax the limb. You take the right leg and you extend it behind as seen in the picture above here. Once you extend this passively or you stretch this passively, the iliopsoas muscles are going to be irritated or they're going to lead to pain. Then pain is obviously, the patient will get relief by flexing the right thigh at the hip because this is going to relax the psoas muscle. This sign can also be elicited in patients with pelvic inflammatory disease. The next sign is an obturator sign. So this is seen in a pelvic appendix. So internal rotation of the right hip is going to be causing pain in the right iliac fossa due to irritation of the obturator internus muscle. So what you're going to be simply doing with the knee flexed and the hip flexed, you're simply going to be pushing the foot outwards and rotating the thigh inwards. So this is going to be causing pain in the right iliac fossa. Then the other two signs that you should at least know of if you want to actually go further in your marks on your exams is the Baldwin sign. This is positive in a retrocecal appendix. When the legs are lifted off the bed with the knees extended, the patient is going to be complaining of pain while pressing on the abdomen. Then of course the Bastide sign, which is obviously an obsolete sign, and it's seen in chronic appendicitis where tenderness is felt in the right iliac fossa on inflation of the colon with air. Then some investigations that we're going to order. Apologies for making the slide very bulky, but I had no choice. I just wanted to put everything on one slide so that you have a good understanding of how you should speak of your investigations. So whenever you're asked to speak of investigations, please learn how to classify them. So there are blood investigations that we can order, urine investigations, imaging, and of course we can do some cytology. So blood investigations include a full blood count with a differential. You're going to be seeing leukocytosis. In more than 90% of the cases, the white blood cell count is going to be greater than 10,000 cells. Then usually there is a left shift, so there's going to be immature granulocytes. So if you have no idea what a left shift is, I covered interpretation of the hemogram in my previous video, so I will leave a card right here, so you could just click here and go over there, and I'll also leave a card at the end to help you read the hemogram. So you at the end of that lecture, you should now be able to understand what a left shift is. Then you may perform urinalysis. So this is helpful in ruling out any genitourinary causes of the symptoms. So if you have red blood cells, if you have white blood cells present, this may actually be pointing you towards extension of the appendicular inflammation to the ureter. And of course, significant hematuria, pyuria, and bacteriuria from a catheterized specimen is going to be suggesting that there is an underlying urinary tract pathology as opposed to appendicitis. Do not also forget to do a Gravindex test to rule out any ectopic pregnancy, especially in females. Then you should also perform imaging, so a plain x-ray. An abdominal x-ray is not really useful in cases of appendicitis because you may not get this clear-cut features on x-ray that may point you towards appendicitis. So some cases, in very few cases, less than 15% of the cases, you may actually see the appendicular lith or the fecal lith, and X-rays are often indicated only for patients where you suspect that there's some intestinal obstruction or ureteric colic. So if you're suspecting that there's a renal stone, you may actually pick this up on your plain X-ray. If you're suspecting that there's intestinal obstruction, you may pick this up on your X-ray. If there is a perforation, then do a chest X-ray. You may actually see air under the diaphragm. And we shall also continue the X-ray week videos next week. I hope you have watched all the videos in sequence from episode 1 up until episode 3. If you haven't, please go to the playlist and look for investigations and watch those videos on the x-rays. Then you may also perform an ultrasound. This is obviously sensitive about 85% and specific for 92% for the diagnosis of appendicitis. So some positive findings that you may see on the ultrasound, I will show you a picture in the next slide. You may get an enlargement that's greater than 6 millimeters. So you get this hyperechoic thickened appendix wall that is greater than 2 millimeters, what you refer to as a target sign. So you have this thickening of the appendix wall. You may have an appendicular lith. You may also have interruption of the submucosal continuity. You may have a appendicular fluid. You may even have a non-compressible appendix. So you have to note that the appendix is going to become compressible after perforation. So this can actually give you a false negative. So the fact that the appendix is not compressible is not going to be ruling out appendicitis because it could have perforated. And an ultrasound is actually very good in ruling out some of the gynecological pathologies. It may also rule out ureteric stones. It may rule out pancreatitis, ovarian cysts, ectopic pregnancies. It may also confirm appendicular masses and appendicular abscesses. The much more specific or much more sensitive test and somewhat less specific is an abdominal CT with contrast. So it's very sensitive, about 95 to 98%, but not so specific, 83 to 90%. This is very useful in several other inflammatory processes that may present in similar ways to appendicitis. So some positive findings include a dilated appendix with a diameter that's greater than 6 millimeters, thickening of the appendix wall that is going to be caused by edema. Then you may also have a non-filling of the lumen by contrast or air. You may have a periappendicular streaking, which is obviously densities with perimesenteric fat. You may have periappendicular fluid collection. You may have presence of appendicular liths or fecal liths. You may have presence of a mass or abscess. You may sometimes do a laparoscopy, which is most useful in patients in reproductive age. You may do aspiration cytology, where peritoneal fluid is going to be aspirated using a fine catheter, and this fine catheter is going to be introduced immediately below the umbilicus. And of course, the test is positive if you have more than 50% of the cells being neutrophils, and this is indicated in the presence of infections. But of course, all these tests are going to take some time. So often we just order for a plain abdominal x-ray, a chest x-ray, an ultrasound, and at least a full blood count before rushing the patient to theater. So here's a picture of ultrasound of an appendix in 2 different patients. So as you can see here, this appendix is enlarged. The wall appears thickened. This is a hyperechoic mass. And of course, this is your target sign that you may see over here. So this looks like a target. Then here's an appendicular lith or a fecal lith, which is obviously seen over here. This is a CT scan. Is seen in appendicitis. So when it comes to the diagnosis of appendicitis, it is based on a certain score, which is known as an Alvarado score. It's also referred to as the Montrell's score, first described in 1986. So you can use the mnemonics Montrell's to help you remember the different scores. So each of these parameters is scored out of 1 except 2 parameters, and the total is scored out of 10. So if the patient has migrating pain, that is migrating from the umbilicus to, or periumbilical pain radiating to, or migrating to the right iliac fossa rather, you give them a score of 1. If they have anorexia, you give them a score of 1. If they have nausea and vomiting, you give them a score of 1. If they have tenderness in the right iliac fossa, you give them a score of 2. So tenderness is the one that has a score of 2. Rebound tenderness, you give them a score of 1. Elevated temperature, you give them a score of 1. Leukocytosis, that is greater than 10,000, you give them a score of 2. So leukocytosis and tenderness in the right iliac fossa are the ones which have 2. Then a shift in the left side with neutrophilia on the peripheral smear, you give them a score of 1. So you add the total score. So if you get a score that's less than 5, it means you're not so sure that this could be appendicitis. If you get a score that's between 5 and 6, it's compatible with appendicitis. If you get a score that's between 6 and 9, it is probable that this is appendicitis. If it's a score that's more than 9, this is confirmed that it is appendicitis, and there's absolutely no way that you would have missed it. The management of the condition involves resuscitation, so you do your ABCs, check that the airway of the patient is patent, check that the patient is breathing, gain venous access with preferably 2 large bowel cannulae, start running your IV fluids, and start giving them antibiotics. You can give a ciprofloxacin, plus metronidazole, or if you do not have ciprofloxacin, you can give a broad-spectrum antibiotic, a combination of ceftriaxone and metronidazole. And for the uncomplicated cases of appendicitis, appendicectomy can actually be done. So you can perform various incisions. You can perform what is known as a gridiron incision, which is one of the most common incisions that's done in our setting. So you make an incision perpendicular to the McBurney's point. You may also perform a Lance-Crease incision, which is obviously centering at the McBurney's point, but of course you're following the lines that are there on the skin. And this is cosmetically better because the healing is much better. Then Rutherford's Morrison's muscle cutting incision. So the muscles are cut upwards and laterally. You may also perform a right lower paramedian incision or a lower midline incision when you're of course in doubt and when you think that there may be diffuse peritonitis. You may also do it laparoscopically, which is becoming much more popular and a better option. And you may have a Fowler aware approach where you're cutting the muscles medially over the rectus. So both the open methods, which are the above methods, and the laparoscopic techniques are appropriate, but laparoscopic appendicectomy is going to be associated with less post-operative pain, and of course the patient is going to be staying much shorter in the hospital, and there's better cosmesis, and the patient returns to work faster as compared to an open method. Then post-operatively, you can give 5 days of antibiotics. Metronidazole and cefuroxime can be given. IV fluids should also be given, and once the bowel sounds are heard, oral diet can be started. Then some drugs that you can give for 5 days include drugs like ciprofloxacin, benzopenicillins, metronidazole, gentamicin. Do not forget to give analgesics. And in selected advanced cases with appendicular abscesses, you may initially manage these non-operatively with antibiotics first. Then you can perform percutaneous CT guided drainage of the abscess. And of course, this is going to be followed by development of fecal fistula, but this obviously normally heals spontaneously. Then for perforations, do not forget to perform peritoneal washing and also give this patient parenteral antibiotics. So you may sometimes run into certain troubles when you're performing an appendicectomy. So during the surgery, if the appendix is found to be normal, then you should look for another cause. So sometimes this could be caused by a Meckel's diverticulum that may be inflamed. Then in patients with Crohn's disease, ovarian pelvic causes in females should be looked for. Malignancy should also be looked for. Then sometimes you may find an appendicular tumor. So if you find a tumor, if it is at the tip of the appendix, then an appendicectomy will be sufficient enough. If the tumor, if you're suspecting that it could be a carcinoid tumor, then if it's at the base, then you have to perform a right hemicolectomy. If there is no appendix and the cecum and the tinea should be traced properly, and you should confirm and finalize that indeed there is no appendix. And of course, if there is an appendicular mass or a pelvic abscess formation, you may actually discover this intra-op. This need to be drained. And of course, sometimes you may discover malignancies in the cecum that may be discovered on the table, so you should perform a right hemicolectomy. And if Crohn's disease is actually identified during surgery, then appendicectomy can be done with care if the base of the appendix is normal, but in some rare occasions where the appendix is involved by Crohn's disease, appendicectomy shouldn't be done, but you only treat them with antibiotics and steroids, and if otherwise, a fistula is going to develop when you perform your appendicectomy. So differential diagnosis, there are many things that can present to you with appendicitis. So you could have gastrointestinal conditions such as gastroenteritis, mesenteric adenitis, Meckel's diverticulum, intussusception, typhoid fever, primary peritonitis. You can have genitourinary conditions such as ectopic pregnancies, pelvic inflammatory disease, ovarian torsion, cysts or tumors, urinary tract infection, pyelonephritis, ureteric stones. In children, you may have Meckel's diverticulitis, acute colitis, roundworm colic, acute iliac lymphadenitis, intussusception, lobar pneumonias. In the elderly, it could be due to acute diverticulitis, CA of the cecum, mesenteric ischemia, intestinal obstruction, acute aortic aneurysm leak, then you can have Crohn's disease. In females, you may have a ruptured ectopic pregnancy, ovarian cysts, ovarian abscesses, uveitis, salpingitis, and mittelschmerzer, which is rupture of the ovarian follicle during the menstrual period during ovulation. So some complications of acute appendicitis include relapse and recurrent appendicitis. Sometimes you may have an appendicular mass. So you may have this localization of the infection that's occurring about 3 to 5 days after an attack of appendicitis. The inflamed appendix and the greater omentum, edema cecum, the parietal peritoneum, and the dilated ileum are going to be forming the mass in the right iliac fossa. So this mass on examination is going to be tender, it's going to be smooth, it's going to be firm and well localized, and it's not going to be moving with respiration. It won't be mobile, and all the borders well localized. It's going to be resonant on percussion, and often patients may have fever, even they may have features of toxicity. So you may actually confirm this on an ultrasound. Then treatment is obviously conservative, as the nature has already been the nature of the infection has already been localized, and if it's actually disturbed, it may lead to a fecal fistula. So you just perform some observation, you monitor your vitals, your temperature, your blood pressure, your pulse. You mark them, you make some markings of the mass to identify whether it's progressing or regressing. Cover this patient on antibiotics such as ampicillin, metronidazole, gentamicin, or other drugs. Then, depending on the severity and requirement of these IV drugs, then you can give this patient IV fluids, analgesia, and of course, initially you should insert an NG tube. Then patients usually show some response by about 48 to 72 hours, and the mass reduces in size, the temperatures slow down, the pulse becomes normal, and of course the appetite returns. And 90% of the patients respond to this conservative treatment. And patients are often discharged and advised to come in at intervals of about 6 weeks after for an appendicectomy to be performed. So some contraindications that may be there to appendicular masses: if you are doubting the diagnosis, then please take this patient to theatre. If there's an acute appendicitis in children and elderly, if there's a burst or gangrenous appendicitis, they need theatre. If patients have diffuse peritonitis, they need theatre. So you can manage them conservatively. You may sometimes have an appendicular abscess, which is obviously going to present to you with high fevers, features of toxicity, tender, smooth, dull to percussion mass, which is obviously soft, and it's going to be found in the right iliac fossa, and it's going to lie towards the right lateral and lower side with a clean upper margin but indistinct lower borders. You're going to have this increasing right lower quadrant pain, tenderness. It's going to be fluctuant, and you may actually palpate the mass in the right iliac fossa on the rectal examination, and there may be anorexia, fever, localizing peritonitis, even leukocytosis. Diagnosis may be confirmed by a CT scan. Treatment involves antibiotics, percutaneous or even operative drainage. Then the pelvic abscesses can be drained perectally or through the posterior colpotomy in females. Then you may also do interval appendicectomy after 3 months. Then you may also get perforation as a complication. You may get generalized peritonitis, septicemia, overwhelming sepsis, and death. You may also get a portopaemia, or what is known as a pylophlebitis. So this is obviously rare these days, and it is due to septic portal system thrombosis. It is commonly seen in immunocompromised individuals, and the infection is actually going to be spread into the liver via the portal vein, and it's going to be causing rapid multiplication of these virulent organisms, leading to septicemia, leading to toxemia with hypotension and tachycardia. There may be jaundice, even a tender palpable liver. The patient is often drowsy. Treatment is going to include antibiotics such as amikacin, metronidazole, meropenem. Fluid management can be given, ventilator support, and this is going to be carrying a very poor prognosis. Then sometimes you may get a complication of intestinal obstruction that's due to obstructive ileus, inflammatory adhesions, formation of bands between the appendix and the omentum, or between the appendix and the small bowel can lead to this obstruction. You may sometimes get intraperitoneal abscess formation, which can either be subphrenic or you can have multiple small intraloop abscesses. Then complications that may happen after appendicectomy include paralytic ileus, reactional hemorrhage, which is due to slipping of the suture that is actually placed on the appendicular artery. You may have a residual abscess that may be pelvic, paracolic, local, or even subdiaphragmatic. You may have portal pyemia. You may have recurrent intestinal obstruction, which is due to adhesions and kinking. You may have right inguinal hernia, which is a direct due to injury to the ilioinguinal nerve. You may have wound infection and sepsis in 10% of the cases. You may have a fecal fistula, which is usually drainage of following drainage of an abscess. So you manage this conservatively with antibiotics, IV fluids, dressing. You can give zinc oxide cream over the skin and observe this patient. Most often, the fistula is going to subside provided that there is no distal obstruction by the adhesion, or any kinking, or any specific cause like a carcinoma or a TB. And if it's persistent even after 6 weeks, you can actually perform resection of the ileocecal segment, and an anastomosis can be done. You may also have respiratory problems and DVTs following an appendicectomy. Thank you for spending your time to listen to this review lecture video on appendicitis. If you enjoyed the video, drop a like, drop a comment to show some support. Hit the subscribe button if you haven't. Hit the bell notification icon to be receiving notifications of such videos every time I post. Until next time, my name is Dr. Moses Kazevu. Bye.